Right, can you see the textbook, pneumonia?
I don't see anything.
No.
No, I don't see it.
See it now?
It's loaded. Yeah, we see it.
Yeah.
All right, so pneumonia. So this is the first of two infectious diseases we'll be talking about tonight. If you recall, have you ever seen lung tissue? No, right?
No.
Yeah, because we don't see it in grocery stores. I've actually never seen lung sold in the grocery. We see liver a lot. So the closest organ that it resembles is the liver. So the lungs look like the liver when it's, when it's fresh and all that. So why does the liver or the lung appear red and squishy?
It's vascular.
All right, so it's vascular. So if you go back to chapter 27, if you look at the, you know what, let's go to chapter 27. Let's just quickly review the anatomy. If you look at the structure of the lower airway, all right. So here we just have a little illustration on the right lower lobe is the only part there that they pictured the alveoli, those grape-like clusters. So each lobe will have those structures. So our mainstem bronchus divides into the left and right mainstem bronchi, and then the airways grow smaller and smaller, and the terminal part are the alveoli. So the alveoli are individual grape-like structures. We have about between 30 to 50 million of them, and each of them filled with air. So that makes your lungs expand. Breathing again is made possible by the diaphragm. Diaphragm is usually curved like this. It's a muscle. So when the muscle contracts down, air is sucked in passively into the lungs because the atmospheric pressure is so high and we have negative pressure inside the chest. So breathing, as you can see, unless you're talking or running, for instance, or exerting, breathing normally is effortless. You're not conscious about it. You don't have to exert any effort or think about it because it's all automatic. It's all done passively. And then expiration, of course, the diaphragm simply relaxes, it pushes up, and then just as inhalation was passive, exhalation is also passive, totally effortless. Now, because these are vascular, each individual grape or alveolus is wrapped in a capillary network. Is it hard or is it very easy to infect it?
It's easy to infect it.
Very easy. Plus, the air we are breathing, is it really clean? Is the lung therefore sterile?
No.
No, the lung is exposed to all pollutants. Chances are we walk around the neighborhood. I have many neighbors who have pets. There's dogs everywhere. And sometimes they're not very responsible. So poop dries up. So as we walk around, chances are we're breathing pieces of dog poop, cat poop, bird poop, whatever. So we're not breathing in the cleanest air. In that instance, of course, we have built-in protection, which we'll talk about after the break. That will be under COPD. We have mucus lining, we have mucus production that will trap those. We also have bacteria, normal bacteria living in the airway. That will all plus we have protease, that's an enzyme that will break down debris that is caught by or trapped in your mucus, and they are broken down. So it's quite efficient in preventing everyday pollutants from causing problems in our respiratory system. However, as we age, of course, these structures, these mechanisms built in to protect our airway will of course decline, and then that means age is the number one risk factor for pneumonia. Typically, as you're under 65 years old, your risk for pneumonia is quite low because, again, because of all these structures. So it takes a lot before you get pneumonia. There has to be direct lung injury, such as, for instance, if you aspirate gastric contents, for instance, or if you become bedridden, in which case you are unable to expectorate secretions. So um, the pollutants that you are breathing in are not expelled. So those are the only instances that you may develop pneumonia. So if let's say a younger person develops pneumonia, for instance, we typically consider, is there immunosuppression involved? Is this patient suffering from any uh, condition that will lower the immune system, such as HIV, for instance, or any other immunosuppressive disorder? Again, the risk factors for pneumonia do not include the younger people. Of course, the very young, like infants, yes, but the very old as well. But age groups in between don't typically develop pneumonia. There are different types of pneumonia. The only difference here, the purpose why we distinguish between the types is for reimbursement purposes. There is a huge difference in the reimbursement based on the type of pneumonia. So by definition, it is the presence of excess fluid. That fluid accumulates there because of uh, um, a more of a result of the a battle between your immune system and whatever the causative organism is. So it could be viruses, could be bacteria, could be fungal, for instance, or whatever causative organism invaded or entered your airway. So the trigger are those organisms, infectious organisms, or also inhaling irritants. But basically, when your immune system responds, it triggers a inflammatory response. In fact, the inflammation starts before the white blood cells enter. So once your inflammatory cytokines enter, so it causes severe inflammation, causing your symptoms of the cough, the increased mucus production, the airway inflammation leading to the shortness of breath, etc. But the fluid here is really caused by the inflammatory response to the invading organism. So what is in there? We have several. We have white blood cells, and then as they fight the invading organism, that's what they cause. Behind them is the alveoli, or the no the capillaries. In the presence of inflammation, become leaky. We call that increased capillary membrane permeability. So it's a natural response with any inflammation. You probably notice that whenever you get a cut, for instance, the cut remains swollen, or let's say a pimple. When we were in high school, we get pimples a lot, and the pimple, of course, is very red. It's painful. It's swollen. There's some exudate as well. So with any other inflammation, the same thing happens. Although the capillary leak syndrome here, we're we're talking about is more of systemic, but there can be localized capillary leak, which is good. That way we don't have it systemically occurring. So in pneumonia, we have a local capillary leak. And that leaking, of course, will cause edema. Most of the leaking there will be large molecules that don't normally pass through the capillary membrane. We are in chapter 31. So the large molecules that don't normally pass through the capillary membrane, now they do. So we have um, albumin leaking out of the plasma into the alveoli now, and then water always follows that. So that will lead to the fluid accumulation. So this excess fluid is caused by all of those which I just mentioned. Sometimes, depending on the um, nature or the type of organism, you can have pus accumulation as well. In that instance, you can have pneumonia with empyema. Empyema is pretty much an abscess or a collection of pus inside the lung. So we have different lobes in the lung. So we have 3 lobes on the right, we have 2 on the left. Pneumonia doesn't have to infect all the lobes. Typically, they occur because of gravity. So by gravity, of course, the lower lobes in both lungs are the ones that typically will become infected. If, of course, untreated, then it may spread to other lobes. I already mentioned the types of organisms. These are the different organisms that could cause pneumonia. Let's go to risk factors. So who are at risk for pneumonia? In all types, it's always the older adult. By older adult, we always start with 65 years or older. That's why when we talk about the indications for pneumonia vaccination later, the number 1 question is the age. So age is the number 1 qualification. And then we'll talk about the other indications, because age isn't the only risk factor for pneumonia. I mentioned immunosuppression. So those people, anyway, we'll talk about those people who must receive pneumonia vaccinations and how often. So we have the first type is community acquired. By the name itself, this is not acquired in the hospital. So this is out there in the community, either at home, um, in their own house, for instance. So anything outside or not related to healthcare, especially those who are either unvaccinated, either from the flu or pneumonia, or those people who have chronic health problems. We'll talk about those chronic health problems later. Or smokers. Then for healthcare associated pneumonia, you can include those risk factors up here, as well as the others here. Further, under community acquired pneumonia, it doesn't have to be literally inside a hospital. We know, again, community acquired, these are the most common causes. It's strep or the flu virus can cause pneumonia, or in younger people, for instance, RSV. And this is the typical treatment. It's outpatient setting. They don't have to be an inpatient, although if they have severe symptoms, then they'll be admitted for about 2 days. So the average length of stay is about 2.5 days for pneumonia, for community acquired pneumonia. Healthcare associated pneumonia doesn't have to be occurring while you're inside the patient. As you'll see here on the definition, it's pneumonia that develops within 48 hours of admission. So the admission here doesn't have to be in the ICU. It could be in any regular floor. And in fact, look at the other definitions. if you've been in the hospital for the past 48 hours, for at least 48 hours, and then you develop pneumonia within the last 90 days, meaning if the pneumonia develops even after discharge, but you were hospitalized within the last 90 days for at least 2 days, that is still considered healthcare associated pneumonia. Or like I said, doesn't have to be in the hospital, could be institutionalized like in a nursing home, or this could also cover mental health facilities as well, or homeless shelters, for instance. Or if you received any healthcare therapy, including wound care that involves antibiotics or chemotherapy, for instance, in the past 30 days, if you develop pneumonia, that is still healthcare associated pneumonia. Or even outpatient, seen at a hospital or a clinic for the past 30 days, that is still healthcare associated pneumonia. And we have, of course, hospital acquired if you developed the pneumonia not on admission, but you developed it after 48 hours from the time you were admitted to the hospital for another reason. And most pneumonias develop in the ICU in ventilated patients if they've been on the vent for at least 2 days. That's why we have what we call ventilator associated pneumonia bundles. You'll learn that later in chapter 32. This table also tells you what the bundle is. Like these, for instance, this is the bundle. But right now I'm not testing it yet because it wouldn't make much sense to you without understanding the ventilator. So we'll talk about the interventions or prevention rather for ventilator associated pneumonia in chapter 32, 2 semesters from now. So let's begin with the vaccination. Vaccination, you have to know because you are expected to screen every patient admitted to the hospital for pneumonia vaccination. So this includes, again, every patient admitted for whatever cause, whether it's a respiratory illness or whatever else they came to the hospital for. If they're going to stay in the hospital, they have to be screened for pneumonia vaccination. We have to offer it, not because it will give the hospital money, but it's really for health promotion. So this is our one opportunity to offer the vaccination. That way the patient is protected from pneumonia. I'll send you the link shortly if I can find it. Let me find the email first. Okay, I'll send you the link together with the recording later tonight. So this is from the CDC website. So this is the schedule for all ages, but since this is a adult med surge, I will leave the schedule for pediatrics for Mrs. Buckner. I'll start only with adult, 19 to 64 years of age. Now, if you look at your textbook, the first indication is what? Who should be vaccinated?
Adults 19 through 64.
No, from your textbook.
Oh.
Let me start with the vaccine first. So there are two vaccines available. Used to be only one. We had pneumococcal vaccine before, I think it was in 2000, before 2010, but after 2010, they came out, the CDC recommended two vaccines now. So we have PCV13, which is pneumococcal conjugate vaccine, and then we have pneumococcal polysaccharide, which is PPSV23. The numbers correspond with the number of strains. So PCV13 protects you from 13 different strains, and then PPSV23, obviously, for the other 23. Now, one thing to remember is Prevnar 13 or PCV 13 is only given once. One shot, and then that's it for the rest of your life. You should only receive it once. I'm talking about the adult, okay? Again, I'm not sure what the rules are, what the recommendations are for pediatrics. I'm only discussing the adult. So for the adult, age 19 and older, they should only receive PCV 13 once in their lifetime. Now, the 23, though, this can potentially be given up to 3 times, depending on the patient's scenario and conditions. I'll show you the scenarios shortly. Again, there are 2 vaccines here recommended. Again, why the big deal? Why do we have to promote pneumococcal vaccination again? Why is pneumonia such a big deal? So I showed you earlier the structure of the lung. So each alveolus, each air sac is wrapped by a capillary wall. So once you get pneumonia, is it hard or easy for that infection to go from the lung into the bloodstream and cause a systemic bacterial infection?
It's not hard at all.
Not hard at all. Very vascular, so it's very easy for this pneumonia to develop into sepsis. So that's why if you look at sepsis later in chapter 37, the number 1 cause of sepsis is pneumonia. So this is what we're trying to prevent in the first place. So prevent pneumonia, therefore you prevent sepsis. Okay? Because once you go septic, not all people survive sepsis. They may come in with pneumonia and then never go home, right? If they develop sepsis. So again, there are 2 vaccines here. We have 13 and 23. The CDC is specific with the guidelines. So let's begin with the recommendation. So we start always with age. So this is 19 to 64. So let's say we have a 65-year-old or older patient. So I'll go back down to 19 to 64 shortly. Let me start with the 65 first, as this is the first criterion. So if a patient is 65 years old, let's see. Right here. If you're just 65, you don't have any of these conditions. No, otherwise healthy. Okay, you're a healthy 65-year-old patient. You're not diabetic. You're not a smoker. You don't have any HIV. You have no CSF leak, no cochlear implant, nothing. You are very healthy. Your only problem is you got old. You turned 65. So now you have a risk for pneumonia. So the recommendation is if you've never received a 13 at all, then you will receive 1. Is that clear? So I'm 65. Let's say I'm 65. No health problem, no diabetes, no smoking history, no immunocompromised conditions, nothing. I'm just old. I'm just 65. So my recommendation, the recommendation will be I will receive PCV 13. So I get one today. I'm also eligible for PPSV 23. Okay, now I received PCV 13 just because I never got to receive it. I've never received it. So I get it today, and then 1 year later, I will get a 23. Okay, we'll just use 13 and 23 to make it easy. So I've never received the 13. I'll get one today, and then 1 year later, I will receive a 23. Now, if I'm still alive, I turn 70. Actually, it won't be 70 because by the time I receive 23, I will have been 66, right? Are you with me? Because I received 13 today. I'm 65, so when I turn 66, 1 year later from when I received the 13, I'll get a 23, so by then I'm 66. So 5 years later, when I turn 71, I will receive one final dose of PPSB 23. So I will receive only two 23s. Okay, because that will be my last dose. There has to be 5 years between my first one and my last one. Okay, again, granting that I never received 23 before or 13. So I come in today, I'm 65. You ask me, you're my nurse, you ask me, have you ever received pneumonia vaccine? No. Would you like to have one? I say, yeah, sure. Okay, so I will get the 13 today. Then next year, probably be hopefully at my doctor's office, not in the hospital. So I'll be offered the 23. And then 5 years later, from when I first got the 23, I will get a second and last 23. So currently, those are the recommendations for age 65 and older with no other conditions. Any question on the 65?
Yeah, so I just want to make sure. So the shot you're getting 5 years after is going off of the 23 shot you got 1 year after the 13 shot.
Yeah. So the clue is this one. So between it, granting you're healthy, okay, you don't have any chronic condition or immunocompromising disease. So I'm healthy. I'm just old. I get a 13. So between a 13 and a 23, there has to be 1 year between those doses. And between a succeeding dose of a 23, there has to be 5 years apart.
Okay, I follow you. Thank you.
All right. So now let's say I come in. I'm not 65. I'm 45. All right. So do I qualify under the age? I'm 45.
Yes, you qualify.
I qualify?
Oh,
Based
between
on
19 and 64?
no, based on age. Do I qualify for the pneumonia vaccine?
No, not
No.
unless you have something else going on.
Yeah, the age requirement is 65. So based on age, no, I don't qualify. However, age isn't the only qualification. The other indication is if I'm between 19 to 64 and I have, number one, I have these conditions here. So I was born with, a hearing problem. I got a cochlear implant, or I have CSF leaks for whatever condition. So these two conditions here puts me at a unique immunocompromised state, wherein I am very sensitive or very high risk for respiratory infections. So therefore, I must be protected from the pneumonia. So I will receive a 13 and a 23. So this is the CDC recommendation. So I'm between 19 to 64, but I have CSF leaks or cochlear implant. So the CDC, I must receive a 13 and a 23. So I will be given the 13 first, and that will be the only time I will receive 13. I'll never receive 13 again. I should not receive 13 again. I should only get it one time. So I'll get it today, and then, but then the CDC recommends I should also get the 23. So when can I get the 23?
A year later.
A year after.
Oh, it says here
8 weeks later.
2 months later. So 8 weeks later, I'll come back. I should get the 23, and then that's it. So I live my life. Hopefully, I don't die. I reach 65. Now, what will happen to me when I reach 65? Because now I qualify for the age. Will I get another pneumonia vaccine?
Do you have to wait 5 years like you did before?
Well, I'm 45 now. So when I turn 65, that's 20 years later.
Right, but you had the 23. So do you wait 5 years? Well, okay, so you can get it again, the 23.
Yeah, it's been over 5 years since I got
Yeah.
the dose. Yeah, so I'll
Okay.
get another 23 when I turn 65. And if I live to 70, can I get another one?
Yes.
Yes, right? So this is the unique situation that I was referring to earlier. So because I have CSF leaks or cochlear implants and I'm between 19 to 64, based on age, I don't qualify, but I qualify based on my condition. So I get a 13 and a 23, 8 weeks apart, and then that's it. That should protect me until I reach 65, because now the dose that I'm getting at 65 isn't based on the CSF leak or cochlear implant anymore. That one I'm receiving for 65 is now based on my age. Because I'm 65, now I have another condition that will put me at risk for pneumonia. So I get a 23 when I turn 65, that's my second dose. And then my third and last dose will be 5 years later, which is about 70 when I turn 70. Any question on that one? Question? All right, so let's proceed. Now, if I have any of these conditions, I'm 19 through 64 years old, I have any of these chronic conditions that puts me at risk for infections. Okay, so I have an immunocompromised state. What is the recommendation? Now I get 113 and 2 doses of 23. Are you with me so far?
All of them together?
Okay, well, of course, not at the same time. So here is how you give it. You give the 13 first, and then 8 weeks later, I get the 23.
Okay.
And then remember I said there has to be 5 years between 23 doses? But the second 23 must be given 5 years after the first dose. So how many doses of 23 have I received now? 2, right? Because I got 113 and I got 2 doses of 23. Now when I turn 65, do I still get a 23?
Yes.
Yes, and that would be my last one. So basically, you get 113 in your lifetime once, that's it. And then you can get up to 3 doses of 23. So this is another scenario where you could get 23. Because you received 2 before you turn 65, or let's say you were 62 when you develop leukemia. Okay, so I'm 62. I developed leukemia. So I get a 13 today, then 8 weeks later, I get the first of 2 23s. Now 5 years later, which is now I'm 67, now that second dose is still based on leukemia. All right, so I still have one last one this time based on my age. So that will be my last one because we can only get up to 3 doses of 23. Any question on that scenario?
Professor, really quick. So the first dose of the 13, that is only given once in a lifetime?
Yes. There's 3 evidence that you'll need a second one. So
Okay.
that will provide you a lifetime protection. But for 23, you need you kind of need a booster,
Okay.
right?
Yeah, thank you.
Okay. And then finally, I know we have 2 more. So if you have, if you're a smoker and you're between 19 to 64, the recommendation is you must get 123. So I'm a smoker, I'm 45 years old, I get a 23, that's it. When I turn 65, I have never received a 13. Can I get a 13 when I turn 65?
No.
Yes.
Yes.
Yeah.
I never received it. This time I'm now at risk for pneumonia based on age. So I will get my first and only 13. And then as long as it's been 5 years since I got the 23 based on my being a smoker, I'll get a 23 when I turn 65, and then another third and last 23 5 years later, if I'm still alive. But if I have an alcoholic, you get 1 dose of 23. And then when you reach 65, I'll get a 13. And then 1 year later from that, if it's been 5 years from when I got this 23 dose right here, I'll get the second 23. And then 5 years after that, I'll get my third and last 23. Not that hard, right? Yeah.
Professor, will we get the link to this?
Yeah, I'll send it today.
Okay.
All right, let's go back to the textbook. So that's it. So the number one, your best action here is to prevent pneumonia, and your best intervention for that is, of course, to get vaccinated. There are, of course, other interventions here, chart 31-1. So these are the other ways you can prevent pneumonia. However, your best chance is still the vaccination, because we can't really do all these. I mean, we can try, but it's extremely hard. So your best chance really is the vaccination. All right. So if you have limited mobility, then try to get out of bed, at least in a chair. If you can't walk, and get out of bed, go on a chair. And both the flu and pneumonia vaccination are encouraged. Remember, one of the causes of community-acquired pneumonia was the flu. It was the Haemophilus influenza. Avoid crowds. Do these. Okay, these are what we call pulmonary hygiene. Turn, cough, and deep breathe or ambulate. If you have any respiratory equipment, clean them. This is referring to BiPAP, CPAP. Or if you have the incentive spirometer, do the same. Clean those.
Professor, can you fix your screen? We can't see what you're highlighting.
You have your textbook, right? This is chart 31-1. All right, if you don't smoke, then stop smoking. Yeah?
Say it again, Professor. You cut out.
Yeah, if you don't smoke, then start smoking.
Okay.
All right, eat healthy, get enough rest and sleep, increase fluids, and that's it. Let's go now to treatment. Now the treatment, you'll notice, isn't going to be specific or exclusively for pneumonia. The interventions we talk about here will be applicable to TB, tuberculosis, to COPD, even asthma. Okay, so the interventions for respiratory disorders is really the same. It's common, with the exception, of course, of steroids and antibiotics, because not everybody will receive antibiotics or steroids. But all the rest of the interventions, I'm talking about nursing interventions, are really the same. All right, so let's start. So let's go to the signs and symptoms first. All right, so pneumonia, the symptoms, by the way, will vary from individual to individual. Most healthy patients who get pneumonia will have these symptoms. However, in the elderly, they may not show the typical symptoms of pneumonia. The early symptoms they'll show is probably confusion, which is a manifestation of hypoxemia. Elderly patients above, especially if they're over 70 already, they won't have the typical presentation of pneumonia. But caregivers, especially nurses, LPNs or RNs, because they know these people, because they're long-term care patients, the moment they see a change in their behavior, change in their mental status, for instance, especially if they have dementia to begin with, but there's a change in their usual behavior, meaning there's increased confusion or they're just behaving strangely out of the ordinary, they will suspect automatically either the patient has pneumonia or has a UTI. Right? So this is how elderly usually present, or this is how they respond to infection. They go cuckoo first before they show the symptoms. So the hypoxia is, of course, the cause. That's why the patient will have shortness of breath. They'll have the tachypnea, the dyspnea, and then followed by the orthopnic positions, meaning they can't breathe well now when they're in a supine position. Okay, so they'll assume these what we call orthopnic positions, or this tripod position is the one commonly seen in chronic conditions, but in acute episodes like this, we may also observe them. There will be, of course, adventitious lung sounds, mostly crackles. The crackles here will either be fine or coarse crackles, depending on the amount of fluid that is accumulating in the lungs, or where in the infection stage we're at. So earlier on, you may see fine, you may hear fine crackles first, and then as it gets worse, then it'll become crackly now. Here's a summary of your signs and symptoms, table 31-1. Please read those on your own. Not all patients, though, will present the same way. Let's say purulent, for instance. You won't always in this, it's actually quite rare. But it's not uncommon to see rust-colored sputum. It will be colorful, okay? Not clear or white anymore. So either yellow, green, brown, but not, or let's say orangey. So that's purulent already. That's pus. Labs, of course, in order to make a diagnosis of pneumonia, it has to be an X-ray. The sputum culture here may or may not be used because sometimes we may not be able to get the sputum. Some patients won't have a productive cough. So the X-ray may be the only testing done to confirm a diagnosis. But of course, it will help if we get a sputum sample. That way we grow the organism so that our antibiotic will be more specific. However, for most of these patients, doctors can make a diagnosis without a sputum culture. They just look at the patient's profile. Remember the types of pneumonia earlier? You know what I'm talking about? The table, differentiating community acquired. Yeah. So if the patient doesn't have the profile, so let's say this patient lives at home, has never been in the hospital, hasn't been treated for anything as an outpatient. So based on that, the doctor makes a distinction based on clinical symptoms and the patient's history that this is not healthcare associated pneumonia. So most probably our causative organism is either strep or or the flu. Okay, and then they have empiric antibiotics for that. So most of the time they really don't need the sputum. However, if it's healthcare associated pneumonia, the doctor will insist on getting a sputum culture because we don't know, because we have so many organisms in the hospital that we need to be specific about our treatment. So again, if it's community acquired pneumonia, it's probably no big deal if we don't get a sputum culture. But once this patient is diagnosed with a healthcare associated pneumonia, then there has to be a sputum culture because we're not always sure about the type of organism. So our treatment has to be specific for that organism. So what will the x-ray show? It's usually what we call consolidation or infiltrates. Infiltrates is the liquid that I mentioned earlier, that we saw earlier. Infiltrates will be, the lung looks wet. The lung has fluid all over, so it will appear as patchy infiltrates. So it will appear in one or more lobes, whereas the rest of the lobes are fine. They still appear black, but the areas that have pneumonia will appear white or infiltrates. Interventions. So this is what I mean by the interventions here will be the same when we go to COPD, we go to TB, we go to asthma, or even cystic fibrosis in pediatrics. So the interventions here will be the same for any respiratory patient. You've probably seen it also in chapter 35. Remember when you got a patient with valvular disorder and heart failure? Remember the interventions were similar, correct? Even the drug therapy was similar? Yes?
Yep.
Yeah.
Yep.
All right, so let's go to intervention. So first, of course, is oxygen. And then we give them an incentive spirometer. Now, although you were taught that incentive spirometry prevents pneumonia, right? Because it prevents lung collapse. Now, it doesn't mean that, they already have pneumonia, then that's useless. Not really. You still include the incentive spirometer because we need it in order to re-expand the lung. Yes, there are areas in the lobe that are collapsed, but you can reopen, or what we can recruit those. You'll hear that term in clinical wherein they say you're recruiting alveoli, meaning you're trying to recover some of the collapsed alveoli. Okay, so that can be accomplished with incentive spirometers and also with some vibratory devices. I'll show you later. Positioning is another thing. So far we have oxygen, incentive spirometry, and we have hydration. Unless, of course, there's a contraindication to fluids. Okay, let's say a patient also has heart failure. Then, as far as medications, we give bronchodilators, either by a nebulizer or by inhalers. Steroids, also either IV or inhaled, or toward discharge, they'll be switched to PO. We can give expectorants if they're having trouble expectorating the mucus. And of course, the main reason they're in the hospital is to get antibiotics. Or if it's viral, then antiviral. If it's fungal, then antifungal, whatever the causative organism is. But most of them are bacterial, so most people get pneumonia. I mean, antibiotics, sorry. We'll discuss aspiration pneumonia another time because the aspiration pneumonia here will develop other problems, namely ARDS, and that's in chapter 32. Okay, so we'll skip the aspiration pneumonia because that's a separate problem. If there's empyema, this needs to be drained because there's no way the body will absorb all that pus. So that pus must be drained. That will be done under radiology. So there's the radiologist will put in a needle and a catheter to drain the pus. So it may be a one-time thing wherein they'll go in and out, or they could leave the drain in and then collect the drainage in a bellows, for instance, a drainage bag. And that's it. As needed, of course, not, maybe I just skip them. If needed, a patient may also be requiring suctioning. Okay, if they have really thick secretions and are unable to get rid of them. So they'll be suctioned as needed. Humidification also, which will accompany oxygen. So up here under oxygen, you will have to add humidification, especially if the oxygen delivery is high, then the oxygen must be humidified. And that's about it. We won't keep the patient in the hospital for the whole duration. They'll only be there for, like I said, the average length of stay is about 2.5 days, meaning they won't complete the antibiotic regimen inpatient. So they'll finish it outpatient, whether it's switched to mouth already or oral antibiotics, or if they require long-term antibiotics, then they'll go home with a central line or go to a rehab facility with a central line. And that's about it. The important thing, again, especially if they've had pneumonia, is to educate them on vaccination. Okay, so as patients get pneumonia, then the more they will need the vaccination. Any questions on pneumonia?
No,
Yeah, Professor, for testing purposes, we're going to use that CDC website that you are going to send us for like, that's what information will be on the test.
Yes, sir.
All right, thank you.
It'll most likely be a select all apply question.
Sounds good, thanks.
All right, let's go straight to TB. This will be short because this is treated simply with antibiotics. And we've already done the interventions, so the interventions will be the same as what we did for pneumonia. All right, let's start. So TB, you're familiar with. This is caused by Mycobacterium tuberculosis. There are other strains, but the most common organism is this Mycobacterium tuberculosis. There are drug-resistant strains. There are other organisms. And all of them, though, are transmitted via aerosol, so they're airborne. They are less than 5 microns in size, so that's why they are airborne. They're so tiny. Now, they are also slow growing. meaning you'll never see a patient exposed to TB today and then show symptoms tomorrow or next week or 2 weeks later, right? So this is a very slow growing organism. It'll take several weeks, probably months before the patient shows symptoms, or may never show symptoms at all. Okay? But doesn't change the fact that they were exposed to TB. So we'll discuss the active and the latent um, infections, because not all patients will develop symptoms and therefore are not always communicable. Okay. So this is the how the organism is passed. So it's aerosol transmission. You don't have to do anything. You don't have to be close to the person. You just have to be in the same room with them, in the same train car, for instance. So basically, you're breathing the same air this person has is breathing, and then that's how you get the organism. So chances are all of us have been exposed, but not all of us will get infected, right? It really depends. So as you can see here, 5 to 10% of infected individuals will go on to have these. And then 90 to 95 won't have severe damage. They'll have these scars, okay? And then the rest of the population will remain asymptomatic. So the organism will just stay in your body, lie in wait until you develop some immunosuppressive condition, and then you get the infection. Okay, so that's why you'll see in commercials, if you watch TV, you see commercials. If you watch commercials for the treatment for psoriasis, for instance, for rheumatoid arthritis, for Crohn's disease. Do you watch TV? And see the
Yeah.
Okay, so the commercials on psoriasis, RA, Crohn's disease. So these conditions are autoimmune, correct? Meaning it's your own body causing the symptoms. Now, the treatment, of course, are immunosuppressants, particularly interleukin inhibitors. Now, the warning for these drugs is always because they're immunosuppressants. That's why you'll see on the ad will say, tell your doctor if you had TB or are prone to TB. Do not start Humira if you have TB or have been exposed to TB, right? So the ad always says that because that's the warning, that if you take this drug and you were exposed to TB, then that will activate the TB. Meaning if you have latent TB or inactive TB, it will become activated. So you will develop TB when you start using those drugs because they are immunosuppressants. So basically what this is saying is it hard or easy to get sick with TB?
Hard.
Easy.
It's hard because it really takes a lot of immunosuppression before you develop active TB. I mean, we can probably, like me, for instance, I was exposed to TB. Not at home, not in the Philippines, but when I migrated here. So I turned positive approximately 14 months after starting to work here. We get the annual PPD, right? So I turned positive not during my first year, it's on my second year of working here. So now and of course, the first thought I had was, I don't believe this. I came from a country where TB is everywhere, and then I never got exposed or sick, and I come here and then I get exposed. Okay, so we have two types. So doesn't mean that you got exposed to a different type of TB. No, it's the same TB organism you got because it's airborne. So you breathe it in. So there are stages of the infection. So the initial infection is when you got exposed to TB. Now, the next period will depend. So you could have a really long asymptomatic period, which is what I had. Now you can have a long asymptomatic period. We call that latent TB. And the part where you become active TB really depends on your immune system. You may never develop active TB. Okay, you may stay latent for the rest of your life until you die. But the active part will only occur if your immune system is really compromised and you develop the active infection. For how that or when that happens really depends on varies from individual to individual. So most likely the patient who is homeless, for instance, or lives in a crowded place, we'll talk about the risk factors shortly. So those are the ones that really get the active form of TB. Any question? All right, secondary TB is different. This is, as stated here, this is a previously infected person, meaning a person who had active TB before and was treated. They can have a secondary one. Usually this is when, let's say, a person with active TB later contracts HIV. So it can be a reactivation. So that one is called secondary TB, meaning they had it before, meaning not latent. Okay, they had active TB. They had active infectious TB, which was treated, and then now it came back. Okay, because they developed some usually HIV. This is a usual case for secondary TB. As I already mentioned, it's slow growing. That's why it also takes a long time to treat it because of that nature. Unlike most infections like pneumonia, for instance, or any other respiratory infection where we treat it for 7 to 10 days of antibiotics, for instance, is gone. This one will take 6 months or longer to treat because, again, its nature is so slow. It grows so slow that you have to treat it over a long time. That way you make sure you get each and every one of them. So who are at risk? These are the people who are at risk. Now for the foreign immigrants part, the immigrants here must have immigrated within the last 5 years. Okay, so the countries are, of course, all Asian countries. So that's Philippines, China, Indonesia, Singapore, any Asian country. Okay, so it's prevalent there. Also in South America and Caribbean also, right? But today, really, it's not really confined there anymore because we have it here, although we have it under control. Also in most countries also. Maybe in Africa, it's still a problem because of access to healthcare. So they still have a problem there wherever you have a geographical area that don't have access to care, because TB is very preventable. Unfortunately, there are still countries that don't have a working health service, meaning it's not covering all of the citizens. So those will remain a problem in those countries. Best way to prevent it, of course, is to the prevention part, which is the vaccination, because we do have a vaccine for TB that's called the BCG, or this is given for all newborns within the first 30 days after birth. It's given to all newborns in most countries, the countries that I mentioned. However, that doesn't provide lifetime immunity though. It doesn't protect the patient for life. So this is probably for 10 years approximately. just like what happened to me. I was vaccinated at birth, so it didn't protect me for life. So the immunity does wane as you get older. So these are the signs and symptoms. If the patient presents with these, they're not really specific to TB. I mean, it's typical of anyone who's sick, except of course the bloody sputum and the fever and night sweats. When we get those, it's highly suspicious for TB. And of course, we ask the patient, what do you do for a living? So if they have these profile, or let's say, remember, this is not only the residents, okay, but also the workers. So that will include us. So we are nurses living, well, we don't live there, but we work there. Okay, so we work in crowded areas. Some of us work in long-term care facilities, or we're nurses in the prison system, for instance, or we go to the homeless shelters, or just the hospital in general, because we are also exposed to untreated persons in the hospital. So they come in, we have no idea they had TB. So we have contact with them, right? Feel free to ask me any questions for it, okay? So how about this one? Do you ever wonder why IV drug users or alcoholics? Does that mean TB is bloodborne?
Could be.
Because their immunity is lower?
Okay, it's really the decision or the conditions that these guys usually live under. Chances are, if you're a junkie, you may be cohorting with people you shouldn't be hanging out with. You know what I mean? I mean, your judgment isn't it isn't very good when you're injecting IV drugs, or if you're an alcoholic, right? So the conditions that you live in, or the where you go, who you hang out with, it's in that sense that they are at risk. Not that the it's still airborne, right? So it's not really the bloodborne. This is referring to the conditions that these people will be in, right? And then you also suggested that it could be also because of their immune system. Yeah, because chances are these people don't have good nutrition, right?
Professor,
Yeah, go ahead.
if someone's not exhibiting any symptoms, let's say even in your case where you didn't know you had it, you didn't have any symptoms, would it be contagious potentially?
What was the question?
Would you potentially also be contagious?
No. I thought I mentioned that. No. Here. So if you have latent TB, which is what I have, you are not contagious because you're not symptomatic. So technically you're not sick. You have it, but you're not capable of passing it because you're not sick with it. Meaning you were exposed, you have it in you, but it's not infecting you. Does that make sense?
Yeah. So even if, say, for example, I was around a patient who had it and then I wasn't showing any signs yet.
Okay. Yeah. As long as the person is asymptomatic, they're not infectious.
Okay. Thank you.
In fact, I'll show you later when they're no longer considered infectious, okay, toward the end of the chapter. Okay. But take note though, latent TB is still treatable. Because remember, if you have latent TB, if you have this, you have the TB inside you. You have the bacteria. The only reason why you're not infected, you're not infectious, you're not sick is because your immune system's intact. However, someday your immune system will eventually, there's a chance it could be compromised, right? So you could develop it. So why not treat it, get it over with, so you don't have to worry about it later? Does that make sense? Which is what I did. I went through the treatment, 6 months of treatment, and so I'm good. I don't have to worry when let's say I contract HIV in the future, or let's say I grow really old and my immune system weakens, I won't develop TB. Does that make sense?
Yes.
Okay. All right. Diagnostic testing. Of course, when you show those symptoms listed earlier, you will be tested for TB. Of course, TB can also be discovered by chance during routine annual physicals. Okay, so because we're healthcare workers, we're required to do that, whether it's BCG or whatever. So we may discover that, before we were negative, now we're positive. But with the sick patients who are symptomatic, then of course we need a sputum culture. So this is the only one that will confirm the diagnosis. There are other tests, but only sputum culture will confirm it. Now, we're familiar with the PPD, so that's the skin test. We have the quantiferon gold. We also have the T-spot TB test. Now, one thing all of these tests have in common is they do not confirm TB. All right, all right here. A positive result in all these tests shows that you were infected with TB, meaning you were exposed to TB, but it will never confirm whether your TB is active or whether it's latent TB. Does that make sense?
Yes.
Okay, so again, what do all these tests do? The PPD, the IGRAs, quantiferon, T-spot, what do all of these do?
They detect TB?
Okay, they only detect exposure to TB, meaning you have been exposed, but can they tell whether what you have is latent or active?
No.
They cannot do that. These tests are useless. They only indicate exposure, meaning yes, you've been exposed to TB, but am I sick with it? They can't tell that. So you need a chest x-ray if you turn positive for these.
Professor, I have a question. So, when you do your annual, like at work, at the hospital, and then each time your PPD is positive, so you have to go through the process every time of getting a chest x-ray every year?
No, depends on the policy of your hospital. Typically, a note from your doctor will suffice that you had a positive test, but then your doctor made sure you are asymptomatic. The x-ray, the frequency of the x-ray will also depend on the facility, because some facilities require an annual x-ray, some require every 2 years, some require every 5 years. So it varies. There's really no guideline from the CDC as far as that is concerned, because all they do is just based on the symptoms. The patient, it remains asymptomatic, so therefore you don't need an x-ray.
Got
But
it.
it's the facility's policy that is going to be followed there.
Okay, thank you.
All right. Okay, you're familiar with the PPD. Most of you have had it. For those who never had it, well, you get it planted and then it will be read at 48 and 72 hours respectively. So it'll be read twice. What the reader will be looking for is induration. Induration is localized swelling and hardness. It's not redness. Okay, it's the area of raised. How high is it raised? So this is the swelling. How high is the swelling? So this is measured in millimeters. Again, this is another test. So PPD, just like quantiferon, IGRAs, and T-spot, do not indicate whether it's active or latent. It only indicates exposure. Also, in the same way, if you have a severely immunocompromised, let's say a patient with AIDS, for instance, or HIV, if the immune system is so low, let's say a white count of less than 500, for instance, they may have a negative test, but doesn't mean they haven't been exposed, meaning their immune system is just so severely impaired that they can't mount a inflammatory response. There is no skin reaction. Okay, so that's the exception for the so this is what we call false negatives. Okay, it may have a false negative in a patient with severe immunosuppression. Another thing here is, oh, okay, so how do we read it? We have another CDC. I'll send this to you again later. So we will divide people into 3 groups. A PPD test is positive in any of these 3 groups. So an induration of 5 millimeters or more is positive if you have HIV, or you had recent contact with somebody with active TB, or you have organ transplants and you learn that we take immunosuppressants for those, right? So if you belong here, then a 5 millimeter induration or more is already considered positive. The reason is we don't expect these patients to, again, mount a normal inflammatory response. So a little bit is enough. So 5 millimeters reaction is already a positive in these groups of people. Induration of 10 millimeters or more is positive in these people. Recent immigrants within the last 5 years from the countries I mentioned earlier, IV drug users, residents and employees of hospitals, prisons, long-term care facilities, mental health facilities, homeless shelters, etc. People working in the lab who handle the sputums and other specimens. Any other persons putting them at risk. So for instance, you may not necessarily be a resident or employee, or maybe you have you're a vendor, for instance, that puts you at high risk. You are a young child, less than 4, or if you are even younger, you're an infant, or children and adolescents exposed to people who are these right here. Right, so those are the high risk categories that this is referring to right here. So a 10 or more is positive in this group. For everybody else who don't belong in the first column or who don't belong in the second column, a 15 millimeter or more induration is positive in the rest of the people. A question on exam will be, I'll give you the patient's profile. Who is this person? What do they do for a living? What is their living conditions? And what is their induration? And then you decide, is it positive or negative? All right. Question?
Professor, what about those who were vaccinated?
Oh, BCG. Okay, I'll go back to the textbook. Am I on the textbook? You see it?
Yep.
Okay. All right, so let's go to BCG. Okay, anyway. So BCG is believed to only protect you within 10 years. However, if let's say you just had, let's say you're from North America, right? So it's not required here that you, at birth, you're given one. Okay, so we're not at that point yet. However, if you're going to be, let's say you work for the United Nations, you're going to be deployed in Africa or any other country that's has a endemic TB population. So to protect you, you're going to be given a BCG vaccine. If you are tested within 10 years of the BCG vaccine, it may give you a false positive. However, to eliminate that, instead of a PPD, we will use these tests right here. These two tests are not affected, even the IgRA. So these tests right here, blood analysis tests, do not respond, meaning they're not affected by the BCG. Meaning if you receive BCG within the last 10 years, a positive test in these isn't because of the BCG. A positive blood test in any of these tests means you were exposed to TB. Does that answer your question, sir?
Oh, definitely. I was vaccinated when I was I guess a baby.
Yeah.
So I always have a positive PPD, and my primary told me that I can't get them anymore because it will just keep on getting bigger and bigger.
Yeah, so no PPD for you, but you get these tests instead. So the blood analysis test is foolproof. They are not affected by the BCG. So you're better off with a quantiferon gold. So you get that test, as long as it's negative, you're good. Okay, so meaning just because you got BCG doesn't mean you're gonna be positive in these. Of course, your PPD will always be positive because of the BCG, because this one reacts to that. However, these ones do not. Okay, the blood analysis tests are not affected by the PPD, the BCG, sorry. All right, let's go now to treatment. So we said because this organism is slow growing, we need to treat it long term also. So there's going to be 4 drugs here I'm talking about active TB, okay? So active TB treatment will be the standard combination of 4 drugs. So the purpose here is to really kill the organism. So that's why we do 6 months to 12 years, to 12 months, sorry. Doctor decides what therapy you're going to receive depending on the strain that they identify. There will be 4 drugs. We have INH, Refam, PZA, and ethambutol. Now the regimen is not very well explained here. So I'll refer you back again to CDC. We have one more here. I'll also send this to you. However, I'm only testing regimen 1. Regimen 1 is the standard treatment for newly diagnosed active TB. They changed the website. Oh, right here. All right, so we're only doing regimen 1. Okay, this one, preferred regimen. Let me go back. So if you go to the to the website, when you click on this, what you do is open this one, treatment of drug susceptible TB disease in persons not infected with HIV. Okay, so this one right here for healthcare providers, the second link, this one, and this is just the preferred regimen. Okay, you don't have to do the alternative regimens. Okay, just this one. This is the standard. All right, so there are 2 phases here. So remember we have 4 drugs, right? We have NH, rifampin, pyrazinamide, and ethambutol. So 4 drugs during the intensive phase, which is 8 weeks. So for 8 weeks, you'll be on 4. 1, 2, 3, 4. 8 weeks. Now, after that's 2 months, right? So after 8 weeks, you will be down to 2. You'll only be on INH and rifampin for another 18 weeks. So that's about 6 months, technically 6.5, because that's 26 weeks total. All right, again, the preferred regimen, this is for newly diagnosed active TB patients. They will be on 4 drugs during the intensive phase, which is 8 weeks. So all 4 during for 8 weeks, and then after the first 8 weeks, for the another 18 weeks, just down to 2.
One question: are you in isolation during this time?
No. We'll talk about the communicability next. Okay, so let's just finish the drug therapy first. All right. Any question on the regimen? Again, I'll send you the link. Okay. So let's go back here. All right. So it's that one is clearer. Although they mention it here for 8 weeks and then 18 weeks. If this makes sense to you, then don't bother with the CDC website. I just prefer that one because that was clearer. So again, 4 drugs for 8 weeks, which is the initial phase, and then the continuation phase, which is another 8 weeks, you're down to 2, INH and Refam only. All right. It's not that easy, you know. I just say, all right, you know, it's not that easy because even when I took it, I was only on 2 drugs because mine was latent. So I was on INH and Refam for 6 months, but that's a long 6 months. You know, I missed a lot of drinking on birthdays, anniversaries, other holidays, events, because I was diagnosed around August. So my treatment was August to February. No, I think it went into March. Yeah, I missed a birthday. I missed Thanksgiving and Christmas and anywhere New Year in between. Yeah. No, because you tend to drink during those, but I can't because look at the side effects of the drugs. So INH, these are your, this is a drug chart, so you know what the questions will be. It's about your teaching and your responsibility. So you have to tell the patient what to expect and what to report, because big difference. So tell them to take it on an empty stomach. This is for INH. You have to take B complex because this drug depletes your and it will cause neuropathy if you don't do B complex. No alcohol. And this one you report. Because this is obviously, whenever they say no alcohol, that means this drug is harmful to your liver. So you can't add alcohol to the regimen. Darkening of the urine or yellowing of the skin or eyes. And then for Refam, this one,
I was on Twitter.
stain your urine. Please
somebody,
take.
I guess he liked it or whatever, or retweeted it, and it was like some dude saying he was just like, niggas be wanting girls with big.
This is also for all secretions. Okay, tells you here all other secretions, not just the urine. Okay, so this will include your sweat, your tears, okay, or anything liquid coming out of you are going to be reddish, orange reddish color. This will affect, Refam will affect your OCPs. So birth control pills will be ineffective here. Again, no alcohol. Then, so of course, no report darkening of urine. For PZA, this causes uric acid buildup. So you could develop gout. To help combat that, increase fluid intake. It also causes photosensitivity. So wear sunscreen and a hat. This one for the drug, it's yeah, same thing. So it's liver hepatotoxic also. For ethambutol, this one causes optic neuritis. So you need a baseline eye exam before starting this drug. So here you have to do baseline eye exams first. And this one, the alcohol part here this doesn't say that it's harmful to the liver. It just says here that the drug does induce severe nausea vomiting when you take alcohol with it. However, since you're using 4 drugs, so that means you drink alcohol anyway because of the other 3. Plus this one will induce severe nausea vomiting when you drink with it. And same one, gout also. So this one and PCA, both of these are going to increase your uric acid. So it's not easy taking these drugs. Plus, what's the profile of the patients that get TB? Are they like you and me? Who are those people again at high risk for TB?
Drug users.
Homeless people, IV drug users. Okay. So you think they'll be okay with giving them a prescription? Here you go, sir. Go fill it up in your pharmacy. Can they do that? Do they even have insurance?
No, they don't.
No. So for those people, compliance will be an issue. So for that reason, here there's a action alert here. So for those people that you definitely think there's no way these people are going to comply. So if they don't comply, they won't be treated. Then they'll remain infectious, and then they'll go spreading TB everywhere. So they'll have to be under DOT. So this is what we call directly observed therapy. This has worked in the third world. So back home, this is what we do. So we do DOT if the patient is non-compliant. DOT, there are varying levels here, meaning you can involuntarily commit them, meaning the Department of Health can have them committed, against their will until they complete the therapy. Nobody likes that, so people eventually comply because the alternative isn't really nice either. No, I mean, you can't go anywhere. You'll be a judge will order that you be committed. Okay, so it's not like they can't say, oh, this is America, I have my rights. No, you don't if you are infectious. Okay, so they will be committed against their will. So most people, become reasonable and then just take the therapy, get it over with. Okay, so until the patient meets the criteria for being non-infectious, they will have to be isolated. It doesn't take long because here, this is when you are no longer contagious. There are 2 instances here because there's a difference between when you can go home and when you can go to work. Okay, because your employer will require a note from your doctor that says you are completely non-infectious. You may return to work. Now, the doctor won't give you a return to work note unless you have 3 consecutive sputum cultures that are negative. Now, the sputum culture is taken every 2 weeks, 2 to 4 weeks. So therefore, typically you'll be out from work for about 6 weeks minimum, because that's the minimum before you get 3 negative sputum cultures. All right, so that's one. And then the other is right here. Okay, so because this patient won't be in the hospital for the whole 6 months, they'll be sent home. They're safe to go home because Most likely, before they were admitted, their family members have already been exposed before we discovered that they had TB. So all we'll do is just test the people at home. So the people they live with will have to be tested just like this patient and treated if accordingly as applicable. They're considered safe to leave their room and go out into the public if they've been taking the drug for 2 to 3 consecutive weeks, plus there is clinical improvement, meaning their symptoms are better. They're not coughing, they're not with fever, none of those night sweats, all that. Plus, they've been on the drug therapy for at least 2 weeks. Then they are no longer considered contagious. All right. Again, your most important thing here is the compliance part. It's really important that they comply with the treatment. Again, it's not easy. You saw the side effects. It's not pleasant. Let's just put it that way. Okay. But you can treat the side effects. Like here, for instance, if there's nausea, then they'll be given antiemetics, etc. Right. So there are ways to manage the side effects. Plus the disorder, again, just stay away from people until you meet the requirements, like this one, for instance, taking it for 2 weeks and then having clinical improvement. All right. And that's it for TB. Any question? Okay, let's take a break.